As we all know, June is National Scoliosis Awareness Month, and we at CPO decided that we must spend some time on discussing this condition and possibly spreading some awareness about it. We have a large scoliosis population that we treat at our clinics, and have immense amount of love for the kids or adults as it may be, and their families, and we feel that this very informative session can be of a lot of help. My name is Amit Banti, and I'm the Clinical Director and CEO at Comprehensive Prosthetics and Orthotics. To make this session very interesting and an amazing one, we have put together a phenomenal group of panelists. Before I introduce them, right, I just want to let a few things be known. This will be a very informal session, so to the audience out there, I urge you to go ahead and type in your questions. We'll try to take as many questions as possible, though I feel with a panel like this, a lot of the questions would get answered on their own. But whatever you're using, if you're on Facebook or YouTube Live, feel free to send us your questions. In case they're not answered, we'll make every effort to get them answered later. So without any further ado, again, one thing I don't want to miss, this is first of our three-part series on scoliosis. So this one, we wanted to make it with scoliosis specialist surgeons, orthopedic surgeons who are in many ways first step of your scoliosis treatment journey, right? We all know that a lot of times scoliosis gets discovered, at home. Maybe a parent sees an unusual hump on the child's back, sometimes asymmetry of shoulder or something else, and then they reach out to a pediatrician or a family doctor, whatever it may be, and the care starts. Sometimes it gets discovered at school screening or something of that nature, or even at their annual medical checkups, right? So whatever the case may be, we thought the first of the three-part series should be about getting a perspective from the scoliosis specialist surgeons. The next one is going to be on the 30th of this month, which is Wednesday again at 7 p.m., where we're going to be discussing about team approach in treatment of scoliosis, where we'll have a scoliosis specialist surgeon, an orthotist, a physical therapist, and a surgeon turned orthotist with experience treating scoliosis globally. So I think it's going to be a very interesting session. And the third one, which we haven't scheduled yet, but we'll keep everybody updated, is going to be about various perspective of various different philosophies of treating scoliosis conservatively. There's many brace types, and I want to make sure that people are aware about all the different types of treatments that are available for the kids and otherwise, as the case may be. So without further ado, let me introduce the great panel that we have today. First, Dr. Lauren Mattini. Dr. Mattini is, hi, Dr. Mattini, how you doing?
I'm great, how are you?
I'm good. So Dr. Mattini is a spine specialist scoliosis surgeon in Chicagoland area, very well known, and works with Fox Valley Orthopedics. And then we have Dr. Ashish Patel.
Hey,
Dr. Patel, how you doing?
Good.
Look at you.
Well, thank you.
Looking good there.
Thank you very much. I think I'm at froze.
I think I'm at froze.
Yeah.
Foiled. Ashish, I think maybe we can just introduce ourselves a smidge.
Yeah.
So we can wait for Amit to come back on. Why don't you start? Go ahead.
Yeah. So Ashish Patel, I work in the area, right? So I think we're down the road from each other.
We are.
My office is Bloomingdale, and I work between Hinsdale Hospital, Edward Hospital, and Elmhurst Hospital. I'm a orthopedic surgeon by training, a specialist in spine. 5 years in practice, and I deal with both degenerative adult spine issues and also pediatric spine issues as well, and have a specific passion for scoliosis. What about yourself, Lauren?
So we share a lot of similarities. I'm with Fox Valley Orthopedics, so I'm more north than you are, focusing in the Elgin and Barrington area, and work primarily with the Advocate, Sherman, and Good Shepherd hospitals, as well as with Amita St. Joe's. I'm now 8 years in practice, and also I would consider myself a glutton for punishment when it comes to scoliosis, and so treat both adults and children, and so have a real love for seeing the kids and being able to help the adults get back into a functioning quality of life.
Yeah. So, I mean, we just introduced ourselves.
That is awesome.
We saw that you got knocked off.
I am so sorry. You know, I've been doing this. I've been sitting in front of this computer all day long just to make sure that everything's perfect, and it had to happen now. So I apologize.
Yeah.
So, all right. So, you know, let's just give it one more minute. Let's make sure that Dr. Ibrahim is able to join. I think he's having some difficulty also. So just let's give it a second, and then
Okay.
we will join in a second.
Lauren, what would be your...
Oh,
there
I'm
he is.
here. I'm here.
There he is.
Hi there.
Okay. Hi, Lauren. Hi, Ashish.
Good to see you again.
You too.
How are you, Kamal?
You too. That was a long time.
Great.
Okay, I think my turn to introduce myself. I am a spine deformity surgeon, or I was, because I retired for 3 years now. And I'm enjoying my retirement. I've been in practice for 40 years, and I have seen it all. And Ashish invited me to be here, although I present the old generation, but I'm going to learn from the new generation, the younger people.
We can always learn from you.
I would
Thank
say
you,
the
Lauren.
same.
Nice. And I must let everybody know that Dr. Ibrahim just flew in from an international trip and should be very tired. But
I appreciate it. I also may have to excuse myself before the end. I have other commitment, and I thought the panel is 6 o'clock. But so if I disappear suddenly, please don't blame the computer. Blame me.
All right. All right. So again, great to have you all, and you know, we'll keep this fairly, you know, like I said, informal. There might be some questions. One of the things I just want to let everyone know that since you know, this time constraints with this, we also you know, if our discussion goes in a certain way,
Amit, you have to speak closer to the computer. You're cutting off.
I, as the moderator, will pull
That's
people
better.
back as needed. Okay.
Good.
All right. So how about I start, you know, with Dr. Ashish Patel. So we were talking about the other day. We were talking about you know, the state or status of scoliosis care in America, right? And we had a really nice discussion about it. There was some great points that you brought up. So I would like you to maybe, you know, discuss that a little bit, you know, for everybody's benefit.
Sure. You know, I think the standard of care for scoliosis treatment in the U.S. is absolutely excellent, and a lot of that has to do with actual overall awareness that we as medical professionals bring to the society about scoliosis and its impact on an individual's health and well-being. And so in the last 10 years, I think when we've made a step forward in terms of clinical research. So clinical research is typically has to do with outcomes, and it was mostly physician-based outcomes. And since that time, in the last 10, 20 years, we've seen a movement towards patient-reported outcomes. And when you take a look at somebody's overall well-being, that could be captured within specific outcome questionnaires like the SF-36 and other outcome questionnaires that are have been, you know, distributed within the spine community to our patients. And when we take a look at these outcome questionnaires, we can see all the metrics and all the issues that patients may complain about when it comes to scoliosis, both pediatric and adult-based. And, you know, with pediatric patients, a lot of that, since They come to your office not really complaining about pain. A lot of it has to do with the potential for issues in the future, and then their current either psychosomatic, how they internalize scoliosis, and then the body dysmorphic issues. And then for our adult patients, not only is there cosmetic factor, but there's also pain and also disability issues, so functional issues. And so what we've done a good job is to characterize those issues and then build some awareness around those issues specifically. So because that there's a lot of awareness around scoliosis, both adults and pediatrics, I think that we've allowed the community to understand these issues. I think we could still do a better job of bringing awareness there. But because of that, we also organize treatments to then try to provide for these patients who are suffering.
One of the points that you made the other day, in an informal discussion, was about grassroots level efforts in screening for scoliosis, which I thought was an interesting point in an overall effort, about spreading awareness.
Yeah, I'd love to get both Lauren and Kamal's input on this, but specifically, like when we take a look at how bringing awareness to scoliosis, and I'm going to talk about pediatric scoliosis, has changed. The key in the philosophy about treating scoliosis, mine specifically, is early detection. Early detection is really the fundamental key to treating patients, because you've now have options of treatments. If you have early detection, you have options. If you have late detection, you don't really have that many options. You have surgery. So I think all of us, even though that we practice orthopedic surgery, would love nothing more than to have a patient that we can detect early, and then observe that patient and potentially brace or prescribe physical therapy and avoid surgery. That's really the key to what we do as practitioners. So early detection has changed in our community from being a mandated school screening type situation, where school nurses, pediatricians, and everybody were always geared around doing the forward Adam Bendon test to capture people. And then because of the high false positive rate, we've gone away from mandating school screenings. And so I think that we suffered a little bit around early detection, especially around places of low socioeconomic status and access to healthcare.
Dr. Mattini, what's your take on that? Especially, I think one of the things that's close to your heart is also adult scoliosis, right? So, if you want to comment on both these situations, that would be great.
They are two very different animals in the grand scheme of things. And then there's the mixture of the in-between, which is a progression of idiopathic scoliosis as an adult. So there's, I think, to really second what Dr. Patel has said, is early detection in kids is key for idiopathic scoliosis. We would, in all costs, try to avoid surgery as much as we can, despite the fact that I'm sure we all love operating, or did when we were in on it. But in kids with scoliosis, the whole point is to find it and treat it without surgery at all costs. And that is typically with bracing, depending on their age. Even if we just have to observe it for a couple of years and do some therapy. There's the Schroth method, which there are many physical therapists in the area who are licensed in that. So for kids, in that perspective, I think that there are probably an in-between of mandating it in schools versus not doing enough at all. And I think that we've come up with a couple of different guidelines to help guide pediatricians. The biggest piece of it is not having to screen after they're skeletally mature, after they've hit puberty. If they didn't have it before, 14 in girls and 16 in boys, and chances of them getting it at that point are probably 0. And so even if they have a small curvature at that age, it's not likely to progress to anything requiring a big amount of treatment. And so the earlier, the better. So finding scoliosis in kids, particularly girls the age of 10 and boys the age of 12, is typically their kind of first onset. If they're going to develop it, they might have a small curvature at that point. Then that gives us many years of growth left to treat them conservatively and help guide their spine growth with bracing. Then we can talk about adults till I'm blue in the face, but that's a whole different can of worms, and that comes from degeneration of their discs over the course of their lifetime. There are some children and who are treated non-operatively with their curvatures as idiopathic scoliosis, that then their back will change as they become degenerative in their 50s, maybe 60s, and so they get treated differently than the de novo degenerative scoliosis who may not have ever had a scoliosis diagnosis in their lifetime. And so I really think there are probably 3 very different categories here, all of which require detection, all of which will probably require some element of treatment, even if that's benign neglect, just as an observation to know and educate the patients on what their future is going to hold.
That's great. I think one of the things that I find very interesting is your point on de novo degenerative scoliosis and various treatment methodologies that might be available out there for that purpose. And again, I come from the orthotic intervention world, and I do get to see a fair amount of those patients, and we try to treat them when we can. Maybe it's for keeping the or it could be for pain management, things of that nature. Maybe later on we get a chance to get you something like that.
Sorry, I didn't hear the last thing you said.
I said if you still have some time later on, I'd love to get your take on that.
Oh, for sure, absolutely.
Okay, awesome. So, Dr. Bryan, one of the things that you talk about is the breast study, right? In terms of the overall standard of care. Love for you to elaborate on that and talk about it.
Okay, the breast study was very well controlled. The study about the effectiveness of the brace was led by a well-known academician and surgeon, Stuart Weinstein from Iowa City, and involved multiple centers around the country and internationally. And the evidence was very strong in support of the brace due to change of natural history with bracing for scoliosis that the National Institute of Health had to stop the study and publish the results so everybody can benefit. And I think there is 2 issues came out of that study. Number 1, or 3 issues I should say. Number 1, the brace is effective almost 70% in management of early detected scoliosis, which completely different from the natural history. Number 2, the brace is dose effectiveness of the brace is dose related. More hours in the brace is better. And number 3, anything less than 12 hours and less in brace is useless. So since the study came out, and that was an honor for me because was presented in SRS meeting when I was president in Lyon 2013, that study now is a landmark, and we use this data or in the management of scoliosis with bracing.
Got it. So, those are all great points. A lot of those studies, especially Stuart Weinstein's study, provides a lot of guidance to us also as care providers for scoliosis and how we approach the treatment of scoliosis. Would you like to, or anybody else, comment? I think you touched upon a great point, right? A lot of times we have different surgeons or physicians prescribing different number of hours for orthotic intervention. I think that is always a sticky point or something that's debatable.
See, I think
not debatable.
Yeah, no,
that's what the study proves.
that data is so critical because just as you're mentioning, Amit, the fact that some surgeons or people who take care of scoliosis wouldn't even brace because of such bad poor compliance issues that we had with bracing. Now, bracing has dramatically changed from when we prescribed it 40 years ago. you can fit it under your clothes. I think some of the psychological issues that these children would have that would have practically make it impossible for for compliance for brace wear have now been streamlined to this plastic custom-made orthosis that fits under the clothes. So I think that the data the data definitely leans on the practitioner to really push the agenda of wearing the brace, and then you have to incorporate the parents into the whole thing as well to try to get them to effectively implement the brace when you're not around. I mean, you see the child maybe once every 6 months, and you hope that your advice sticks. But between the orthotist, the physician, the parents, the Schroff physical therapist, everybody in a very well-organized way can try to lean on the child to wear the brace. And I have to say, I treat a fair amount of kids with scoliosis. With the consistency in advice and the backing of the parents, I definitely stress brace wear more 20 hours or more a day. And I think that most of the children that I deal with definitely comply to that.
I definitely agree with that. I will absolutely stress early on, wear it as much as you can, right? And so if you tell them that they only need to wear it 12 hours because that's what the study showed, then somehow they'll manage to wear it less. But if you tell them to wear it 20 hours or 21 hours and take it off for the 3 hours after school for after school sports, ballet, whatever they're doing, then their shower before dinner, it's like, well, pop it on for dinner and you wear it the rest of the night and the rest of the day into school. Because as soon as you start giving them a little bit of leeway, they will take it and run with it. And, oh, well, my doctor said this. And mom will say, well, the doctor said this. And so the period of growth, you're never going to predict when they start that growth spurt. The growth chart helps a little bit, but every kid's a little bit different. And if they're not in that brace 12 plus consecutive hours at a time, then it won't be effective. And I think that's what the study showed. So there's no leeway, and there's a whole lot of education that goes into that. I know that in your line of work, Emmett, there's a lot of different things that you guys have been able to do in the braces, heat sensors and the like, to help monitor these kids and their brace wear and keep them accountable, right? Or keep the parents accountable, because some of the children are too young to really know the difference. So maybe you can touch upon some of the science that you guys have developed to help us with that.
Well, I think compliance is key, right? And a way to manage and monitor, right? So there's these small devices, sensors called compliance monitors, and a lot of people in Chicagoland area and other places are using those. So essentially incorporating those sensors. Sometimes without even telling the patient, but the parents know. And essentially, that's a device that provides the data every time the patient comes back for a follow-up as to what the wear pattern is, right? I mean, just to understand if the curve correction has not happened, what may be one of the many, there could be many reasons, right? Is brace, the wear time one of those reasons? So I think that is something that's getting more and more usage. But again, there's an issue where, reimbursement is a big problem a lot of times. So a lot of times it's a cash, pay for the patients. So billing for it becomes a challenge sometimes. But definitely, compliance monitors are there that are being used these days, and we can touch upon that in future. Dr. Ibrahim, seems like you'd like to say something on this. I know that you have some really important views on this.
You're muted.
You're muted, Kamal.
Sorry, thank you. Thank you first. Over the years, I had to adjust my hours for bracing according to the patient's response, compliance, family and mother's acceptance, etc. And there is a landmark study by Stuart Green, I think he was from Vanderbilt. He passed away a few years ago, showing that 16 hours, it was a very good study actually, if you go back and look at it, 16 hours is showing the same results as 23 hours. So I took that as a guide, anywhere between 18 and 23, and I leave that to the family to decide. So they can wear it in school if they have extracurricular activities later, or if they are free, they can go to school without it. As I'm sure Ashish and Laura noticed, the boys would be worse in dealing with bracing. And for that, you spend enough time with them to adjust their schedule. So you end up by getting this minimum 16 hours. So I respect every opinion about hours because there is no hard evidence for any hours. So long it is above the 12 we have from the breast study. And with this part, would you allow me to excuse myself? I have a commitment at 7:30.
Yes.
Great to
Oh,
see
good
you.
to see you.
Thank you. It was a pleasure to see you both and three of you. Since we met before many times, but now it was good to see you. Take care, guys.
Good to see you again.
Bye-bye.
Thanks for your time, Dr. Ibrahim.
Welcome. Bye.
Take care.
Just to touch on the bracing a little bit more, I think, there's a really fun part of treatment when the bracing's been effective over their growth spurts and you scale them back into night bracing only. They're getting their 10 hours of sleep and like try to get that 12. And I think the question came through on the chat when I was just thinking about this is, the growth spurts are the most important for brace wear. And so during, the times of growth, that you can try to monitor that on their growth chart and ensure that their prepubertal time of growth is the most time that they're being braced. And then once they kind of hit that onset of puberty and you're seeing not a ton of change in their curvature and not a ton of growth left at that point, then you can start to bring it down into nighttime bracing, which still could theoretically give you a full 12 hours, which is based on that study, our minimum that we're looking for. So that's kind of one of the more fun parts is they're like, yay, I can go to school without my brace on now.
Yeah.
Even though you hope that they're used to it by now and all their friends are too, but nighttime bracing can be very effective in smaller curves if they can get their full 12 hours in.
That is, I think that's a great point. And I think, especially in my line of work, right, like you talked about that fun part of it, right? So when you fit them with their first brace and they, they spend whatever time before their first x-ray and when they come back and I'm always holding my breath, so wanting to know how did it go, right? Yeah, exactly. Yeah, having my fingers crossed. And then when you see fairly decent correction, I think it's a wow moment. Again, if there is a correction, but that is the point that you really want to start stressing it to the kids and their parents that this is not it. I mean, this is just the start. We have a long way to go. Let's see what you can do by being good at doing it the right way, and I think that's what essentially builds the whole foundation for a great successful outcome. So Ashish, were you wanting to say something before I move on?
No, I was gonna say the same thing. I think some of the fun parts of the bracing aspect is to see them back 6 months, talk to them about bracing. It's unanimously like, I don't mind it, but you love to hear from the kids who've been really, really good about it, and then pull that 6-month follow-up X-ray up and show them, either improvement or stabilization of the curve. That's it's a good feeling. I think that they feel a sense of accomplishment from that.
Yeah. So
the critical part, the critical parts about bracing, obviously, is that it's those mild, moderate curves that and again it goes back to early detection, right? Early detection and bringing awareness, and that's exactly what today is about: bringing awareness. Early detection, bringing awareness means that bracing can be effective, right? Late detection or non-awareness, you could brace all you want for large curves. It's really not going to help. So bringing awareness, early detection is key.
We want to give these kids and their parents options.
Great point. Great point. Okay.
Yeah,
So seems,
there's nothing hard. There's nothing harder to have a discussion with somebody who comes into your office and you're the first like specialist that they've seen, and
Too
you
late.
put up an X-ray that's like 50, 60 degrees. It doesn't feel good. It doesn't feel
No.
right.
yeah.
No, it's hard. It's hard to have that conversation with the parents that, you know, because then they start to feel like they've done something wrong or they've done their
Right.
kid a disservice. And, you know, there's all that's a tough conversation. And you want to be able to give them options. And at that point, at a 65 or more degree curve, you know, they don't have any other options.
Yeah. And you know, I think Lauren brings up a great point about how the parents themselves feel emotionally around that. You know, I'll give you an example that I recently had. You know, a daughter of two physicians, and you know, or I've had parents that have had the same thing where they'll go to the beach. There's summertime. Sometimes they're in school and they're in sports, but these things, even though that they happen very slowly, they happen very quickly during that pubertal growth spurt. And when you start to, when you're not the first person to detect it, and somebody's like, "Wait, have you looked at the shoulders or the rib cage or some asymmetries that have come up?" And the X-ray shows a 40-degree curve. You feel like, "How did that happen?" I mean, but to the best of us, I mean, we miss those things because you're just so used to that routine of like seeing your child, but not specifically examining your child, right?
Ashish, comment on this too. I think one of the things I've seen in the last few years with, I guess, with Michelle Obama's take on childhood obesity is that there's some scoliosis that actually more difficult to detect because of that problem. Is we're not seeing the rotation as much, or we're not seeing as much asymmetry because some of our children are, you know, being, I guess, plagued by our childhood obesity and lack of exercise. And so I think that there's a little bit of a, you know, how do I want to say this? Kind of
I mean,
a social piece of this too that we're not quite getting, that we're missing, right? That there's more to this than just having our pediatricians bend them over and look for curves, you know, because some of those curves are undetectable.
Yeah, I mean that goes back to like access to healthcare, and you know, and you have the areas in which childhood obesity have the highest rates, areas where there's low socioeconomic status, and difficulty with access to healthcare, and even just awareness in general. And so these areas, unfortunately, are plagued with not just scoliosis, but with a whole host of like diabetes, obesity, asthma,
Sure.
all these things.
No, that's great, guys. I just want to pull us back, just keeping time in mind. So, seems like rightly so, we got pulled into the whole bracing discussion. But just talking about bracing and surgical intervention, right? That is always one of the big questions that a lot of people ask. Parents come in, and a lot of times they're talking about, hey, am I going to have a surgery? Or hey, why can't I just get a surgery done and be done with it? Why do I have to wear this brace for a long time, right? So, brace versus surgery is always something that's asked, right? So I wanted to make sure that we have a good discussion on that, so that people are aware, the goods and bads of both, and how we can navigate all that. So I'll have Dr. Mattini, if you want to take that first, and
Sure.
we can bounce it back and forth.
I think we touched on this early on. If we can avoid surgery, we will. I mean, I think Dr. Patel and I are the same. In children, we want to save as many levels as we can, meaning we don't want to fuse discs if we don't have to. We want to keep them flexible. We want to keep them mobile. And so if they're at the right age with enough growth left to help guide that growth in a brace, then 100% of the time, if that's an option, that will be given to the child and the parents. Because if we can guide them in a direction where they may not need a fusion, then at least in my hands, and I assume in most of the scoliosis world, that's the way that we're going to go, because we want to keep them with their native spine as long as possible. We've touched upon this. There are some children who are diagnosed late, and so their curvatures are already at a magnitude that we know from our literature that are going to progress in a fashion that's going to cause them more problems as an adult and continue to get bigger. And so once they hit a certain number, the conversation changes. And it's not necessarily just based on age or what's left of their growth. It's based on the curvature and the number of their scoliosis. So we're going to keep hovering on this. Early detection is key. Girls age 10, boys age 12. We keep looking until they're done growing. But if we need to do surgery, surgery comes in all sorts of shapes and forms. But the goal of surgery is to stabilize the scoliosis so it doesn't get bigger, save as many discs as we can. So there are a lot of selective curvatures that can get fused, meaning screws and rods and hardware and all sorts of fun things. But if we need to do those, we will, and we'll do them in the smallest fashion that we can, meaning as little bones are fused as possible.
I'm gonna paint a theoretical scenario. Okay, so a child comes into Dr. Martini's office, right, and she has scoliosis, and the scoliosis is 20 degrees, and the parents are there, and they find the skull, and they're worried, and the child is 10 years old. She has a lot of growth remaining. She's she hasn't had her first period, and so she's going to grow like another 6-7 inches, and so we're worried.
What's
and they
the Ashish?
20 degrees.
20 degrees. All right.
Yeah, and so they say to Dr. Martini, they say, okay, well, what do you think we should do? And so Dr. Martini, she takes out her calculator and she looks and she says, oh well, I just punched in your numbers, and from what I found, your risk of progressing to a 50-degree curve from all the numbers that I punched in about your family history and who you are is like 95%. So therefore, I think we should just take care of it now, through tethering or something and so what I've just, that scenario doesn't exist, right? So we don't. The trouble is, the science behind scoliosis is that we don't know who the at-risk kids are. The only two things that we know is that the people at highest risk of progression are going to be those that have very early onset of scoliosis, because they have the most growth remaining. And then the people who present with large curves, because those are just difficult to control. Outside of that, we see lots of 20 degrees, 25 degrees. And so we follow this protocol or this algorithm where we watch them, maybe brace them, and then surgery around this number, right? But wouldn't it be so great if we could just plug in some numbers and understand who those people at risk are? So there was this thing that was the Scoli score, right? That was a few years back. And the promise of the Scoli score was to try to do a saliva test, and we can take a look at the genetics and a few other numbers and chromosomal this, that, and the other. And we can predict at a very high percentage who the at-risk patients were and who the ones that weren't at risk of progressing. But now that has fallen to the wayside. It was actually found not to really be that accurate. And unfortunately, we're just back doing the same thing, which is this very protocol-driven observation and treatment of scoliosis. So, when parents come in, they say, oh, should I just, do I get surgery? Do I not get surgery? Well, actually, we just fit them back into the protocol and say, well, we don't know. However, you're at this risk, and these are the things, but we're going to continue to observe and watch you and make sure you brace and make sure you're good around your exercises. And unfortunately, that's the best way that we have to treat our patients right now.
So that's great. So Dr. Patel, you bring up some really good points, right? So I want to touch on some of those, right? So one being Scoli score, right? Scoli score really didn't pan out, and my understanding again is because there was a very small sample size, that was there that it was tested on. So and that's why there were a lot of false positives that started happening, and the reason why it fell by the wayside. Also, costs might have been a reason. What are some of the reasons why you think it fell?
Well, so it was like this, small homogenous group in Utah of people who the Scoli score was validated on, And for a very homogeneous group of people with the very same lineage and let's say DNA sampling, maybe you can make a high predictability of understanding who the ones are likely to progress based on genetics alone, you know? But we know that scoliosis is more than just genetics, right? There's a large environmental factor that goes into this. And one of the studies that I always lean on is the penetrance of scoliosis in identical twins. You know, you can have identical twins and one may have scoliosis, one may not have scoliosis, one may have 50-degree scoliosis, one may have a 10-degree scoliosis, and the penetrance is around 70%. But that in itself demonstrates that genetics alone is not the answer to understanding scoliosis. And so we're still trying to figure this out. There's a mechanical component. There's like, you know, there is a genetic component. There's probably an environmental, like other aspects that go into understanding why there's progression. But, you know, I tell the family the same thing. I'm like, I wish we knew, but we don't. And so, you know, yeah. And there's lots of theories out about it, but it's kind of fascinating still that, you know, here we are in 2021 and we're still scratching our heads over it.
Certainly
Still
would make the conversation easier with the family.
Yeah, it would.
Because it is. It's a lot on the parents of, is this because I dropped my baby when they were an infant? It's like, no, you didn't do this. And is this because they carry their backpack always on their right shoulder? No, we've debunked that too through science. And is it because of this? Like, no, we don't, you know, there's no one answer. And it is what it is. And we know as much as we know now. And I think we're continuing to know more and learning more every year and every day and trying to help the best we can.
So parents out there, stop beating yourself. You know,
yeah.
you know, you're not necessarily the reason, right? So, so before I move on from this you know, bracing versus surgery, and specifically surgery that you're talking about, tethering, right, Shisha? I mean, we've talked about this. Something that that gets asked quite a bit, right? I mean, growth modulation or internal bracing, as it may be called. What is your take on that?
Yeah, I think it's fascinating. I mean, you know, the premise behind tethering is really growth modulation, and the benefits of growth modulation over current strategies of surgery is that we can spare disc spaces. We can use the remaining growth to correct the scoliosis, and therefore the patient can retain their mobile segments and move, and that we haven't created a fusion. So let's take a look. So we're both orthopedists, and if you take a look at the work that was done back in like the 30s and 40s, right? And it was Walter Blunt. Walter Blunt, what he did was that there were people who had angular knee deformities. Okay, so they would have genu valgum, verum, recurvatum, and they would see that some children, their knees or their legs and would grow in this fashion, and so he applied a staple across the growth plates at the level of the knee, wherever the deformity was. So he would change the location of the staple depending on how the deformity was. So he could correct a knock knee into a straight knee, or a bow-legged knee into a straight knee by applying a staple or some sort of device that would block growth on one side and allow growth on the other. And I mean, this is amazing work. And so they use that same concept to apply staples in the spine. And back in the 30s and 40s, we just didn't have the technology that we do now. And the spine, being that it's a multifaceted, you know, multi-segmented system, doesn't work like the knee, which is a single joint. And so these staples that they applied would fail. At the same time, you know, Paul Harrington came out with his fusion device, which was the Harrington rod. And so it worked so well by those standards that they just gave up on the growth modulation aspect. Now, it was so successful in the knee, but we didn't think about it in the spine again for like another 50 years. because fusion became the standard of care. And so we went through renditions of fusion where we went through distraction of the curve. And then we went to segmental fixation. And then we went to like hooks and screws. And then we went to all screw constructs. And we're really, really good at correcting scoliosis through our fusion systems. However, it still seems archaic, right? It still seems like it's probably not the best way of doing it. And so it's a good thing that the interest level, enthusiasm around non-fusion has grown again in the last 15 to 20 years, to the point where now we've had our first FDA-approved tethering system that's been around for the last year or two. If prior to this, this was a non-FDA-approved treatment that people themselves would seek out because they didn't want their children to be fused. So we're at the point now that people are collecting data around tethering, and with some understandable initial issues, meaning like trying to understand how the tethering system doesn't pull out, and maybe the rate of revision surgery or reoperations is a little bit high. I think the initial data is very, very promising, meaning we can correct the scoliosis and we can spare the motion segments using tethering system. But again, the key is early detection.
Great point.
Agree.
Very informative, very informative. So here's what I'll do, because there's quite a few questions that have come in. I know we're just left with about 15 minutes. I don't know where the time went. So let me take a couple of those questions. Let's, get through them quickly so certain people get some answers. So one of the questions, again, one of the people in the audience has asked, that being in the US, having all the sources and health professionals involved in the spine deformity treatment, why is it so difficult for private practices to work like a real team? Of course, so this is a question that came from somebody who probably is in healthcare, or maybe a patient, guardian of parent or something, maybe seen they've had to go from place to place. So who would like to take that?
Oh man, I'm in on it. I'm a huge fan of the team approach in private practice.
Like here, right?
Yeah, I mean, we're Ashish and I are obviously technically competitors, right? But we don't operate in the same hospitals, so we're not competing against each other for patients or patient care. And I truly hope in most of my colleagues in orthopedics and around the Chicagoland area, of all the places I've worked in, we do try to do what's best for the patient and not try to get in each other's way, so to speak, right? We want them to be comfortable with their surgeon or their doctor. We want to help their pediatricians. We want them to go see their orthotist on a regular basis. We want therapy. And so in my world, as a private practitioner, I am communicating with my pediatricians and my primary care doctors. I am the phone numbers of all of my physical therapists that I work with, my orthotists that I work with. And so it may be that this particular person hasn't found the physician who is working in that team fashion, because I think that that's a common culture, at least in the way that I've been trained and the way that I practice, that I am not a sole woman on an island and I cannot do this by myself. I don't ever pretend to, because more often than not, as Dr. Patel and I have said, we're not really the ones who are making these kids' scoliosis better. You are, right? As the orthotist, we're going to try to brace you as much as we can in the hope of detecting them early with our pediatrician colleagues or our athletic trainers in the schools. And so that team approach, I think, is really a magnitude that we need to accelerate and really grow, because it's something that I totally cherish in my practice.
Awesome. Very
good. Well said. I think the team this. I think that what you've done, Amit, is that you've made sure that you're well informed about when the patient is coming back to office, making sure that you align their visits to your orthotist's office in and around that follow-up period, so that you can then follow up as well adjust as necessary. I mean, these elements are critical, and so part of that is finding the right team, right, as Lauren suggested. So the ability these days to have access to a lot of different people and different teams, I think that you have to go to somebody that you feel comfortable with, and someone that treats you or gives confidence in your skill set of working as a team.
Great. There's another question. It's about Cobb angle, and from a person in the audience, but it is very much in line with the last big question that I have for you guys in a few minutes. So I want to get through one last thing before we get there, before our wrap up. Um, so the next thing that I want to talk about, and I think everybody has touched upon it quite a few times, role of physical therapy, especially specific specialized physical therapy. I think it's very important. A lot of we feel that it should be along with the orthotic intervention and everything else that goes on. So love to hear from you guys, some specific modalities that you like to use, certain different types of therapy, or what kind of care plan you like to look at, things of that nature for as far as physical therapy is concerned.
Yeah. So I think we unanimously think they can come in with no complaints of symptoms. They can come in with pain complaints, right? So typically, when they're in their observational, conservative type window, we prescribe Schroth physical therapy. And Schroth physical therapy is functional physical therapy around trying to derotate the scoliosis in which the patient has. And so you partner with a physical therapist who specializes in Schroth physical therapy. It's a licensed or a special certification that teaches them that. And all of that is centered around functional physical therapy around scoliosis. And I find it very useful in patients who have issues of pain complaints due to the imbalance, the muscular imbalance that's caused by the scoliosis. We've done a lot of work in the analysis and the gait analysis of scoliosis. And these people when we take a look at their functional limitations, they don't move quite the same way as somebody who doesn't have scoliosis. And so obviously there would be a very specific scoliosis therapy, that is prescribed for them. Lauren, what are your thoughts around that?
I absolutely agree. I think that therapy is one of the most underrated pieces of healthcare out there. I think it is one of the more important pieces of our team. They're the ones who get our patients moving, and in more ways than one in the adult population, make our patients feel better, right? So typically if the spine surgeon can't do it, then I find the therapist can. So in kids with scoliosis, I will oftentimes use Schroth more with the adolescents who are pretty well done growing with a curvature that's not surgically needing to be fixed, right? So somewhere in like the 20s, the 30s, even sometimes the low 40s, that are a little uncomfortable with how they look. They don't quite reach criteria where we want to do a big surgery on them. And so that might help them kind of adjust some of their functional means in their spine. I'm a huge fan of yoga or Pilates, which there are a lot of postural exercises that occur, core strengthening, shoulder and hip opening, stretching techniques that occur through those types of exercises. But I think PT early on, even in the bracing kind of years, particularly in kids who aren't physically active. There are some very kind of introverted kids who like their art and computer science, which is wonderful and stimulating, but the physical activity is second to none as far as promoting muscular growth and balance awareness, and helping them maintain that excellent posture that they're searching for, even while they're being braced. And so I think it can be utilized in a whole host of different children, searching for kind of the right answers as to how to make themselves feel better.
Makes sense. Makes total sense. As a matter of fact, in my practice, every time we get a referral for a scoliosis, orthotic intervention, that's one of the first questions I ask. Are you having therapy? If not, why? I mean, because there are certain orthopedic surgeons. I think most that we work with, like, can you guys hear me? Okay, but there are times that I see that they do not get referred, and sometimes it's almost like a difficult conversation, that you need to have with the parents, and also finding the right therapist. I think I love the way you put it, Dr. Martini. I mean, they're the most underrated. I mean, not most. I mean, they're very well recognized there, but I think they don't get sometimes enough recognition for everything that. So kudos to them. So one more question let me take, and then we'll go to everybody's closing comments, if that's okay.
Mhm.
There's a parent who's asking, my 9-year-old daughter was recently diagnosed with 27-degree curve, and will be molded for her first brace next week. Any advice on how to nurture her emotional/mental well-being during this process, as this diagnosis is rocking her little world? Rightly. Great panel discussion. Thanks for offering an educational opportunity on Facebook Live. So who would like to go first?
Yeah, so people are typically nervous around the unknown. And when you first have a diagnosis, there's a lot of questions that may come up, especially when you have an x-ray that's presented in front of the patient and the family member. And it's pretty striking, that's inside your body. And for a 27-degree curve, even though clinically you can pick it up, for the most part, it's not as dramatic as the x-ray itself. And then when the x-ray shows up, it's clear as day. So I think through education and understanding the actual process or the scoliosis itself, I think one can learn more about it, and learn that having that scoliosis is not the end of everything. It's in fact, you have an opportunity, right? So this is the window of opportunity that you have to make an impact through physical therapy, exercise, and through brace wear. And so I think that this is an opportunity, and through education and learning, and there's many portals that are out there. As the Scoliosis Research Society have an amazing portal for patients to learn more about scoliosis. And then there's also aspects where they can share stories with other people who have had scoliosis. So that's what I would urge them to do.
I think one of the things that I try to instill even in my adult patients is we're all not 100% symmetric. So we're not unique from each other in the setting that we're not 100% symmetric. Some of us have longer legs, some of us have longer fingers, some of us have funky little toes. So this is part of what makes you you, and it's not necessarily a bad thing. It doesn't need to define your activity. It doesn't need to define you as a human. You can use it for good, and you can use it for your own education, and helping other children as you move on with your diagnosis and your treatment. But I think some of the things that we've done from our side of it to help with that too is we've made braces a whole lot cooler looking. So they're definitely more fun. You can pick colors and help make that part of an everyday outfit. We've tried to make, I guess, treatment a little bit more fun with physical therapy and different methods, teaching good exercising and good habits. And I think, again, having a physician, pediatrician, your spine surgeon, your physical therapist who are there to coach you along and encourage you to do good work for your body and be good to yourself can always kind of mentally help, treat the symptoms of all of that too.
No, it makes sense.
Yeah, that's great. I do the same thing too. I mentioned the fact that you have to love the body. and embrace the differences that you have. You know, I have one
Yes.
eye that's a different size, my ears are different shapes, and so that one person may have scoliosis, and so embrace it, own it.
Great point. So we're almost at that point that we need to start wrapping up, but I still want to make sure that we have your input on this big question that I've been talking about, right? So, I'll have both of you make your last comments or wrapping comments or whatever you want to call that. But the question is, and something that I would have loved Dr. Ibrahim to be there. There was a panel, a conference that we attended together quite a few years ago, where we were both speakers, and it was around balance versus correction. And so I want to leave, as we end this, I would love to hear from you guys. This is something that's debated often in various circles. And I'd love to have a consensus. So let's see what you guys think. What is more important, balance or correction?
Balance.
No
Yeah,
questions?
I think no,
Balance. 1000%. Eight times over. Every single time.
Perfect.
Who wants to walk with their head in a different direction than their hips?
Just to have a straight spine. Yeah. No. And Ashish, you're
more important in adult scoliosis is balance.
Yeah.
Right?
I want to look balanced. I don't want to look here and there. So, Ashish, you disagree, right?
no. I I think that's exactly. I mean, we're, thankfully, again, a lot of data around that, but balance is so critical to just function itself.
Perfect. I'm glad we all agreed. There were no fights. It was a great panel. So, from all the audience out there, all the different people involved, parents, children with scoliosis, I want to thank both of you and Dr. Ibrahim for taking the time. I know you guys are very busy. So thank you very much. And also, I want to thank the whole, all the audience out there for taking time listening to us. And I'm very, I'm hoping that you're going to go home or go back with a little more awareness about scoliosis. And do not forget to tune in next week at 7 p.m. on Wednesday to hear about scoliosis treatment, a team approach. With that, thank you, everyone. Have a great night.
Thank you.
Thank you, Amit.
Thank you. Bye-bye. Thank you, team.
Thank you.